Well, to continue on with our below the knee and also calcium modification theme here, we're going to invite up Dr. Chandra, who's going to talk to us about the Disrupt PAD BTK2 trial. So thank you very much, Venita.
Thank you so much. Good morning. It's a great pleasure to be presenting the 30-day results of the Disrupt PAD BTK2 study on behalf of my co-PI, Aaron Armstrong, and all of the study investigators. So we've already talked a fair bit about below the knee. I don't need to go into this. We're obviously very aware these are smaller vessels, long diffuse lesions, and these heavy calcified long diffuse lesions are what we're seeing more and more of. Of course, the distribution is both in the media as well as the intima. Balloon-based IVL has now been around for a bit, and of course it allows the application of sonic pressure waves to modify the superficial and deep calcium, and the key is to do it at a low pressure. So you're really allowing the energy to do the luminal gain as opposed to the angioplasty. There's been some early studies, BTK pilot study, as well as the below-the-knee cohort of the observational study that have demonstrated favorable safety and efficacy within infrapopliteal stenosis, but no studies really with longer-term follow-up. So this is where the Disrupt BTK2 study came in. Again, it's a prospective, multi-center, single-arm study of the Shockwave medical peripheral IVL system for the treatment of calcified below-the-knee lesions. All of the patients were core lab adjudicated, both angiographic and duplex core lab. I really want to dive into the inclusion criteria a little bit. We tried to make this a real-world study. The patients were allowed to have lesions up to 200 millimeters, Rutherford categories 3 through 5, but limiting the 3 to only about 20%, and including even patients on dialysis, because those are those patients that we need this technology for. Our endpoints included primary safety endpoint of male pod and a primary effectiveness endpoint of procedural success defined as less than 50% residual stenosis for all treated target lesions without serious angiographic complications. This is our consort diagram. There were 250 patients enrolled in the study, of which 242 ultimately got to our 30-day follow-up. Our primary effectiveness endpoint, there were 305 lesions, of which 268 had post-IVL imaging and 290 had final imaging. Few patients did not have imaging available or didn't do that final imaging, so that's where they went. Baseline medical history is shown here, 71 years old on average, 72.8% were male, and you can see here, real-world CLTI below-the-knee patients with significant hypertension, hyperlipidemia, 70% were diabetics, and again, 15% were on dialysis, so a really complex patient group. 45.6% had wounds, just demonstrating, again, the CLTI population. I mentioned already the majority of patients were Rutherford 4 and 5, and by part classification, the majority of patients had moderate to severe. Actually, majority had severe calcification. Lesion characteristics are shown here, and you can see, despite allowing up to 200 millimeter in length lesions, I was a little surprised that the mean lesion length was only 76 still, but about 30% chronic total occlusions, and of course, the length of calcification was quite significant. This chart shows our procedural results. 34.6% had predilation. Notably, this study was done prior to the E8 catheter, so the majority of the patients had the S4 catheter. Some of them had M5. There was a 97.5% successful IVL catheter delivery. I know this has been a huge concern and worry with the S4 catheter, but as you can see here, the results were pretty good. Post-dilation was performed in about a third, and about 5% had stents implanted. Notably, this is about half of the rate that we saw in the below-the-knee observational cohort. Primary effectiveness of residual stenosis of less than 50% was once again chosen just to be consistent with prior IVL studies and was seen in 97.9%, but a more clinically relevant post-hoc analysis was done with a final residual stenosis of less than 30%, which we found in 74.1% of the patients. Diameter changes as shown in this chart. As you can see here, the average MLD was 0.7 pre-IVL or pre-procedure and increased to 2.3 and 2.4. And this percent stenosis, it's almost uncanny. It's like every single IVL study ever has the same chart of percent stenosis with a reduction to less than 30% post-IVL. Angiographic complications are shown here. There were 3 angiographic complications. 2 of them were actually core lab adjudicated findings of perforation that were not identified by the physicians and were really of no clinical impact. There was 1 patient who had abrupt closure due to a significant flow limiting dissection. These chart shows our primary safety endpoint at 30 days, and you can see our major adverse limb events or postoperative death was 0.8%. This was primarily driven by 2 amputations, which were due to worsening of wounds and infection and not thought to be due to the procedure. This was our 30-day change in Rutherford category, certainly a little early to start to see significant changes, but we had about 60% of the patients that wounds were healing or healed, and you can see the impact with a significant improvement in Rutherford category by about almost 50%. We also did quality of life questionnaires, and you can see across the various areas, there was a total 4-point improvement in quality of life at 30 days, which was statistically significant. So in conclusion, this is the 30-day results of the Disrupt Below the Knee 2 study. I think it really is a complex and actual challenging cohort that we enrolled in the study. Obviously, our follow-up will be out to 2 years. This is very early. But the 30-day reveals favorable outcomes with this device with low major adverse limb events and complication rates and a significant reduction in residual stenosis. And most importantly, I think, an improvement in patient outcomes, right? So in terms of quality of life in Rutherford category. We will look forward to the 1-year data where we will include patency and target lesion revascularization. Thank you.
Great research. Really excited to see what you come up with. It's really great preliminary data. Did I read correctly that only a little over a third had post-dilatation? That's encouraging. Please explain.
Yeah, I mean, it was, unless there was there were some criteria where you were mandated to do post-dilation, but if you had an adequate improvement in stenosis, you did not absolutely need to have post-dilation. And in general, we recommended about a 1.1, a little bit oversizing of the lithotripsy, but staying at a lower pressure balloon. And I think that really resulted in, as you can see, quite significant luminal gain.
Yeah, just to jump on that, it's funny because I was looking at the flip side of it. About a third of patients did pre-dilation or operators.
And you thought that was low?
I'm sorry?
Sorry, continue.
Yeah, no, I was just saying, that I always pre-dilate and then I deliver, and the 2 comments there is, 1, it was still successful, but 2, it delivered, which has always been the challenge for below the knee intravascular lithotripsy, is getting the balloon to the lesion. So any comment on the pre-dilation side?
Yeah, I was surprised by that as well. We had 8, I think it was 8 delivery problems. It wasn't actually, one of them was actually a generator problem, so not even the balloon. 2 of the patients, the lesion was beyond the length of the balloon, and it was only 5 patients out of the 250 where they couldn't cross. And despite only 30% predilation, I have to say I uniformly predilate as well in this study, so I was a little surprised.
Yeah, I'll kind of add to that. You have very low complication rates here. The only time I have ever truly had a complication with this device is whenever I was pushing it too hard or I didn't predilate. So I've sort of moved to wanting to predilate more just to help prevent any kind of a complication. I like how safe it is and how you're able to get across. I'm very excited also, of course, to use the E8 more because of the links.
Absolutely.
Venita, thank you for sharing these early results. I mean, these are really complex patients, and you had 50% of patients undergoing dialysis. So what's your first, say, gut feeling? Do they react differently? I mean, these are the cases I'm always afraid about. And the calcium seems to be a little bit different than in the other patients. Do you have any?
Yeah, I agree. I think that what we really need for those patients is to treat their entire vascular bed, right? Ideally, so maybe javelin is the way to do it. That is absolutely a challenge. But I think we have to study these patients. Like, these are our patients. These are the challenging cases that we have. And so, I mean, I think if you are getting more pulsatile flow in those areas where you treat, it's impactful, as you can see, so.
Congratulations, beautiful data. I'm struck by the male rate being so low at 30 days, given the comorbidity of this population, so many on dialysis. Can you talk a little bit about the selection of the patients in the medical management for those first 30 days, particularly in the dialysis population where we can't use a lot of drugs that we normally would?
Great question. 30 days is certainly still pretty early, and I agree. I'm expecting the results to be a little bit different given the patient population. Standard of care was what was recommended, and I would say the postoperative management was based basically on our physicians. So maybe we picked the good sites, taking good medical care of our patients.
Wonderful. With that, well, thank you very much, Venita. Wonderful presentation, and we'll see you back up here in a few minutes. Yeah.